The views, information, or opinions expressed during AAOA broadcast series are solely those of the individuals involved and do not necessarily represent those of the American Academy of Otolaryngic Allergy, its employees, or members. The AAOA is not responsible and does not verify for accuracy any of the information contained in and assumes no liability for any activities in connection with these broadcasts. The primary purpose of this broadcast series is to educate and inform and does not constitute medical or other professional advice or services. Advertising which is incorporated into, placed in associate with, or targeted toward the content of this product without express approval and acknowledgement of the AAOA is forbidden. These broadcasts are available for private, non-commercial use only and may not be edited or modified from their original form or reproduced for distribution.
Thank you to whoever out there might be listening, and also to my distinguished panelists. As usual, we'll just do a couple of quick introductions. And so I'm Jennifer Villwock. I'm an allergist at the University of Kansas, also an otolaryngologist, of course. I don't have any disclosures or anything else to note for this talk. And then Dr. Patadia.
Hi, my name is Mona Patadia. I am obviously an otolaryngologist as well, do quite a bit of rhinology, allergy, and facial plastics. I'm out in Chicago at Loyola University, and no disclosures as well.
Dr. Stachler.
Hello, I'm Rob Stachler. I'm from the northern Detroit area. I have been in private practice for the last 5 years, and I initially was in academics for about 23 or 4. And I do otoloryngic allergy, laryngology, and rhinology to a point of doing sinus work and a little general there, here and there too. So I have nothing to declare as far as conflict of interest, and I'm happy to be here tonight.
Great. And I think that this, when we reflect back on the just-in-time Zoomcasts that we did, coming on almost a year ago, it feels like, and now I think some of the things that we're discussing are going to be a little bit different. But same theme. So, the pain points and ways that we've had to shift and pivot in our practices, are ever changing. And so I'm curious to hear from both of you, what were some issues early on in the pandemic that were very successfully troubleshot, and what are issues that you're still kind of learning from?
So I was trying to think through it, and it's amazing, somewhat crazy that this has been going on since March. And so I think one of the big things is the flow of allergy patients. And of course, for us in Chicago, things were shut down from about mid-March to early May. And at that point, people were not getting any shots, really just the offices were shut down. But since early May, we started everything up. And I think early May, the question was, who's gonna come in? Do patients wanna come in for shots? What's our protocol? I think we've nicely progressed. I think there's a pretty good flow. We just make sure our patients are spread out. Everyone just gets a temperature check at the door, which of course we know is not accurate, but it is at least a bit of a screening tool. Everyone is screened 24 to 48 hours prior to coming to confirm that they have no symptoms or no recent exposure. And when they come in, they get their shot as usual. We just spread them out further in the waiting room. So my allergy nurse has done a great job of taking out several of the seats. So there's only a limited number of seats available there. I do find that there's more patients that are getting sublingual immunotherapy now. So my newer patients that are starting, when you give them the option, they're quicker to jump to the option of slit. And I had just started that about a year ago in my practice, right before COVID hit. So I'm so thankful that that's a part of my practice.
I jumped on board right away. I was really never closed for a long period. Maybe I was maybe closed for 3 or 4 days just because I'm a single provider, private practice, and I had people to rely on me, and people that, even though the ORs and everything was closed, people still had nosebleeds, earwax. They were scared about coming in, but we persevered and moved on and wore our PPE. I think some of the problems with getting PPE right away, I still have difficulty obtaining N95s, actually ordering them and getting them. Gloves are a little bit scarce to come by, and the nitrile gloves, they're harder to buy, but I'm able to get them. They're of course more expensive. I've been doing allergy shots, a few in the office. I still do a ton of slit. So my people are coming in to get their next vials, and they're um, social distancing. I really like the fact that all of my magazines are gone. My waiting room is half of what it used to be. Nobody runs into anybody else. If we have any of our patients that see another patient while they're in our office, that's a mistake on our account. Nobody runs over each other. If I'm using the back door as an egress route for patients that are leaving, and they know just to take 2 rights and they're right out front of where I used to be. So they're getting in the bat cave, so to speak, the bat entrance. I have wiped things down and tell people there's hand sanitizers everywhere. We have plastic up in front of the of our receptionists, and it works like clockwork. People know that when they're coming in that they are taking a spot and they have a cherished spot, and if they don't show, they're not going to get the opportunity to come back in. People know that if they don't show, there's a fee involved in not coming. I really try to streamline who's coming in. I still do a ton of telemedicine when I need to. If there's anybody under suspicion, they don't come in. If there's a sore throat, they don't necessarily come in. I do that via telemedicine. So I've done a lot as far as adopting the telemedicine, doing it, and I think the practice is better because of it. If somebody can't do telemedicine, I'll do telephone, but I try to do some telemedicine.
Yeah, I think for me too, telemedicine, I mean, I think that's an amazing thing that has come out of COVID, is that option for patients. So my pre-op surgical patients are probably not the best patients to get telemedicine because I still need to examine their nose. But there's certainly the allergy patients when they're coming in just for a check-in. Those are the perfect patients for telemedicine. And some my every Q6 month check-ins that are checking in on how they're doing on their biologic agents, for example. So that has really been great. The other thing I was thinking about was I used to spray each and every patient when I was scoping them prior to COVID with some sort of neosynephrine lidocaine combination. And of course, initially with the pandemic, we stopped spraying patients. And I know some of the data is variable on that. But what I started doing was I started using a PED scope in pretty much all my patients. Now, granted, you're not decongesting their turbinates, but it's extremely painless for patients. I mean, it takes 10 seconds and you can get a great look. So I found myself doing that. I still do that on most of my patients without decongesting them, and you can still get a great exam. So that's something I'm going to continue to do. And I think most patients, for them, it's just a lot. I think a regular scope is painless anyways, but it's just a lot less uncomfortable, much more comfortable than a regular scope.
Are you flexible or are you rigid?
So it depends. Flex for just a diagnostic purpose. I use rigid for a post-op debridement, but otherwise I use a flex. What about you, Rob? Because I know you do a lot of laryngology.
I love the flexible scope for getting around in the nooks and crannies and getting around the corner and looking into the maxillary sinus when I can, and it's a lot less painful.
Yeah.
I do what I can. I use instead of the aerosolized medication, I'll use the little spray bottle of Afrin. I'll half and half it with lidocaine and make sure that I'm from a distance and spraying it so that there's no chance that you can get, cross contamination or they can contaminate the bottle. And so I like that technique. If somebody's coughing a lot, I'll try to not be right up in their face and try to get away. So.
Yeah, and I don't do this, but I heard on some of our other AAOA podcasts recommending having patients spray with Afrin before they come in. So that's an option. Just another thought, unrelated to the spray. I was just thinking about my allergy nurse. any patient she needs peak flows on, she actually just has them step outside. Our hallway leads directly to the exterior of the building. So she feels more comfortable having them just step outside to do the peak flows. So that's been her way of adapting to that scenario. Now, obviously it's mid-January, so it's a little less comfortable to be outside.
Yeah, I think now's a good chance though for if you want to try something new. For most of my patients, I've found that they appreciate the explanations, and I think these are opportunities to try some things that otherwise we would not have changed our practices. Because I'm just like you guys in terms of trying to defer the sprays if possible. And, some patients are skeptical if that's all they've ever known. But if you say, no, we're trying to, decrease exposure to everything, let's just give it a try. I'll use a smaller scope. I think sometimes they're open to it. And I know that in our practice, Dr. Stachler, you were mentioning, the unidirectional flow of people and, being very intentional about that. That's something that I try to verbally reinforce to the patients as well. Like, oh, we're going to follow me out because we only have people going in one way, especially for those that are a little bit more afraid about coming into the office. I think it helps them to know, all the different things that we're doing. Like we also have signs on the doors that we are make a show of like flipping, or at least I do, when we leave the room and it says, now this room needs to be processed. And, we write on with a dry erase marker when someone else can go back in, just to make it very clear that we're doing everything that we can. So I think most of the patients appreciate the extra explanations regardless of, what we're doing.
Yeah. One of the new things that we'll be struggling with now is that our facilities are going to start offering the vaccine for our group 1B patients. So I'm located at a satellite, and I think they're going to start next week. So I'm excited, of course, that our health system is going to help the city give the vaccines, but I think my nurses are really concerned because of the flow of the vaccine patients being in line for my patients also coming into the very same building to come into clinic, and kind of just having more exposure than we would like. So I'm not sure exactly how that's going to work out. I'm going to actually meet with some people in our building next week or late this week to make sure there's a better flow for that. So I can report back on that, on how that works. I had a question. I was just thinking about some other things, and I think something that's evolved a lot at my hospital is our policy on testing patients prior to surgery. So it started that everybody was tested. For us, it was the Abbott 2000, the PCR nasal swab, especially if you're having any sort of nasal or airway surgery. However, the question is if they've already had COVID, right? So initially it was, if you already had COVID, you don't need to get tested again if you're having surgery a few weeks later. But then it changed to no, even if you've had COVID, you need to get a PCR test. And now I'm hearing that it goes back to if you've had COVID, you don't get tested again within 90 days, as long as you don't have symptoms. But my question that I'm unclear of is what happens after 90 days. I don't know if you guys know what your policies are at your hospital, but it seems to be shifting, I feel like, on a Q weekly basis everywhere.
Yeah, I would agree with that and echo that sentiment of, especially I'm a person that goes to multiple different hospitals. And so it seems that oftentimes one is waiting for the other to make some sort of determination, and then they just want to mirror those policies. But, it's hard when the available tests, shift, and then the evidence shifts as well. So for the most part, we are still testing all of our pre-op patients. And,
regardless of
if we think that they're a lingering positive, then sometimes we'll just say, well, the last time they were symptomatic was, way back when, as a justification for proceeding. And then, there is at one of the facilities, we can do one of the serum antibody tests, but honestly, I don't know how helpful that has been in terms of actually doing any sort of preoperative triage.
Right. And I've had some lingering patients. They're 5 weeks out from their COVID that they were symptomatic from, and their PCR is still positive. And then at that point, the question is, why did we retest them anyways? Because we're going to go ahead. But I think after 3 months, the question is, can they recontract the virus? And is that a true positive or not?
Our facility still does it. Still tests 2 to 3 days before, tells people to relative quarantine. Like they'll do it. I operate on Wednesdays. They'll do it the Thursday or Friday before and make them quarantine over the weekend.
Yeah.
Still.
Good. My surgeries are on Wednesdays as well, so they're pretty great. They'll test on Monday, which is great. The result comes back on Tuesday. But the big change is if they've had COVID in the last 90 days, they will not test them again. And because the thought is it could be a lingering positive.
What do you do in the operating room differently? Do you rinse their nose and nasal cavity with iodine, saline? What do you do any of that?
No, Rob, I'm not doing it. I've read all the literature and I know there's thoughts of it. The only difference is I make sure that everyone's wearing eye protection, and I do prefer that everyone's wearing an N95 in the room. And everyone, again, mostly is tested. So I've not done that. Knock on wood, I haven't had any issues with it. I worried when I did it. I felt like if I was taking a syringe and irrigating, I was afraid that I'd be aerosolizing things more or making things worse than helping it. What about you, Jennifer? Are you doing it?
I'm not doing any of the extra irrigations or anything. I've been fortunate in that I actually have not had that experience personally, in terms of proceeding with someone that's been a lingering positive. I do still treat otherwise all of my patients as if they are, a presumed unknown or positive, just because, I think the last several months have shown us the best, but also the worst in humanity. And I'm a relative skeptic as to people's ability to truly, self-quarantine and do the things that we ask them to. And so in all of my cases, I'm wearing an N95 and eye protection and all of that.
Yeah. And I pretty much throughout all of clinic just wear an N95. I mean, granted, in the beginning, especially with the shorter supply, I would just wear the same N95. It's probably gross. I mean, for several weeks, if not a whole month. I mean, at some point, I would pretty much throw it out when it was smelling, which is, again, not very hygienic. But at least I felt like I wasn't misusing or taking extra N95s. But as long as it still had a seal, I think it was okay. I know it's not recommended to use it for that long, but it seemed to do the trick for me.
So were there any especially creative solutions that your practices implemented or that you've seen others implement for some of these kind of common issues that we're all having?
I was thinking back, one of our laryngologists just snips a little hole in the mask when he scopes patients, and that was his way of not exposing the whole nasal cavity. The only thing I've done personally is just I try to keep the mask on at all times, right? Because you find patients come in and then what they want to do is take the mask off and they just want to talk for 20 minutes, right? So I have them keep their mask on while they're talking for those 20 minutes. And then really right when we're starting the exam, I'm very efficient about examining their ears, their neck, their cervical exam. And then I just have them quickly take their mask down to look in their mouth. Once I'm done with the mouth, I put the mask, cover the mouth up again, and then just quickly look in the nose and be done. And that's how I've adapted to it.
Yeah, I'm through the same way. I mean, I've got people that will take their mask off and I'll be like, put your mask back on. We'll keep it on as much as I can. Then I'll just pull it down just to see the nose and put it back up while I go get a tongue blade, and I'll come back and drop it down just to look in the mouth, pop it back up. I feel around it underneath to make sure I can feel the submandibular gland and the parotid gland. I'll still feel around the mask and maneuver around it unless it's an N95 or something to that nature. I have the hardest time with, the thing is, I don't really have a good camera system where I can project the image up. I would like on my wish list or to-do list is to get a really nice camera system. But my problem is, even when I have an N95 and I have my goggles, or I've got something covering my glasses that I'm wearing as I'm examining the patients, I'm still getting a ton of fog. So yeah. I'm in the middle of a scope and I'm fogged or my end of my scope is fogged, and I'm asking the MA to get me a 4x4 to wipe it off. And I'm, tempted to try to get creative with some of the extra defog to just defog everything before I begin. Maybe put some Dawn on the inside of my goggles before I begin. I haven't done any of that yet.
Yeah. So I do have a tower. So I guess I'm looking at the screen. So my scope's not fogging, but I did have an issue with the goggles. And this is just a quick funny story about my daughter, but she has glasses and she'd always complain that her glasses were fogged. And of course, as a mom, I'd just say, you're fine, don't worry about it. And then of course, she heard me talking once to one of my nurses and I was complaining about how my goggles were fogging in clinic. And she pointed out like, well, of course that's bothersome. So you're absolutely right, Rob. The goggle issue was a problem for me. And then at some point I just stopped wearing goggles, which is not a great idea either. But I did find that doing the defog on the lenses was helping a little bit, just having, and then also sometimes putting your goggles over your mask, but it's not perfect by any means. And I do find myself sometimes taking them off in the middle. And then when I put it on my desk, I'm just wondering if I'm going to infect myself more by whatever was on that desk and contaminating myself. I know, I mean, the hospital did give us shields that we're supposed to wear. They're just so large and bulky. Right. I tried to use it on a COVID because I did take, a COVID positive patient to the OR for some bleeding. And on that patient, I tried to use it, but even for that, it's just so large and bulky, it's almost difficult to even maneuver with it. So those are things that I'm still struggling with as well.
Yeah, I'm hopeful that as I see more advertisements on the internet, I'm like, surely someone is going to find the ultimate solution to this problem. And, I've been seeing some of our colleagues posting with new, fancier goggles that supposedly don't have those issues. So I'm not quite ready to invest $100 or more in a pair of goggles myself. But if they tell me that it works long-term with their experience, then maybe that's something that I'll do in the future.
I saw a really cool welder's mask, but with a nurse that was working on COVID patients. And it's this big mask that came down, and she said, you can get it at Amazon for $40. And it was really cool because the inside of it has some type of defog, so it never fogs up. She said, you got to order the one with the defog. And I thought it was really cool. So, but I never purchased one because I wasn't in that situation, direct impact.
I have seen some, not for the goggles, but I've seen some prototypes of masks that people have had me trial for patients. And ultimately the goal would be that the patient would purchase, or you would charge the patient for their specialized mask that had a little hole in there, and then you could scope them through the hole. So again, this is not my idea. And as a rhinologist, you trial it, but at the end of the day, I think it's probably just faster to just quickly take it down, take a quick look. And as long as you're protected, I think we're okay. The question is, we don't have any negative pressure rooms. And Rob, like you said, what do you do when a patient sneezes, right? I mean, of course, a sneeze or a cough now is so different than it used to be back in January of 2020. I mean, patients were coughing and sneezing all the time. It didn't matter. And now all of a sudden, everyone in the room takes a look. But I mean, we try to not use that room for a little bit and air it out, but it's at the end of the day, I don't think I know of a patient that's contracted COVID from our office, to my knowledge. Of course, there are patients that have had COVID within a week of leaving the office, but I don't know that that was related to being in the office.
I would agree. We don't really know what we don't know. So I would say that, we think that we've done a great job, but we really don't know ultimately.
Yeah.
I think we really cleaned the rooms incredibly well in between. And I even help when if I'm have a single MA with me, or if I don't have a full staff, I'm wiping down and cleaning up and doing my fair share to keep everything moving in a forward fashion.
Yeah.
Do either of you have any changes that you're expecting to implement? As I know we were all hoping that 2021 would be a brand new year and all our woes would be gone. But, in the midst of this pandemic continuing, even with the vaccine and everything, are there any changes that you guys are planning to implement soon? Or is it kind of staying the course and then just being aware of information as it evolves?
Yeah, I think, like you said, Jennifer, this is a great time to be innovative and constantly reevaluate your practice daily. I don't have a big change at this very moment, other than trying to figure out the flow of our patients versus the patients that are coming into the building for their vaccine. So that's the next big stage at our hospital. The one thing I can say is patients that ask me about the vaccine, because that's been the new conversation as well. What do you think? Should I get the vaccine? I have a lot of allergies. Do you think I'll be okay? So I do love the guidelines that have come out by our academy and that also have come out by the AAOA. And I do emphasize that if they don't have a history of prior anaphylaxis to a prior COVID shot, then there's really no true other contraindication to the vaccine. I'm trying to make sure that we spread out our shots from the day that they get their vaccine, but those are the main changes right now.
I had one patient call me yesterday or a couple of days ago asking they were afraid that they were going to get an anaphylactic response and wanted an EpiPen for their first shot of the vaccine. And so I took a step back and I said, wait a minute, they already have all that there. If they're a regular testing site or vaccine site, they have all that there. You don't need to do that. So I think as we move forward, I'm just trying to, keep moving on, keeping positive. All of my staff are vaccinated. It was all by their choice. It wasn't, I did not make them. And, I'm excited because I see things moving forward and people are now in my neck of the woods getting vaccinated. It's not to say that I'm going to be willy-nilly and just do whatever and not be careful. I'm going to still wear my N95 and do the best I can. I usually wear something over my N95. Yeah. I'm still doing at least one mask with a cover over it or something along those lines. I'm a little leery about the new strains that are more virulent. So I'm kind of nervous about that, but I think we're going to weather the storm, and I think things will get better as more of us get vaccinated and have herd immunity. I'm looking forward to those times. I'm not taking it less serious, but I think that we need to just keep moving forward. I'm excited. In Michigan, we were completely shut down. The restaurants were closed. So now we're open up, but it's only 25% that they're allowed to do. So we'll kind of see how that goes and if our numbers go up. But it's the real deal. And people Beaumont Hospital is one of the biggest COVID hospitals in our area. And I've been up on call and I've seen the distress in the nurses' eyes and the weariness in their demeanor and the post-traumatic stress that they've been under. And I haven't personally had that experience, but I really feel for them and am very cognizant of what's going on.
I think I echo what you say, Rob. I think it is with the vaccine, we don't know all, but it has provided some hope, I think, for all of our staff members and for many patients. And I think one thing that I reminisce about is when I went back to operating early May, I remember exactly, it was May 4th. I had a bit of apprehension going back to the operating room because I'm thinking in my head, I remember that day I was doing elective cases, super elective rhinoplasties. And I'm thinking, am I doing the right thing here, right? And I even had called the patients and said, listen, this is a really elective case. Do you really want to go in for surgery today? And we don't know. And those patients really wanted it. And I remember thinking, I'm not sure if I'm doing the right thing. But since then, looking back, we've been operating and still very busy since May. And I don't think we've had a change in outcome. I don't think I've had any increased morbidity or mortality or complications. I don't know that there's been any COVID cases related to being in the operating room. So that's been positive. So now I feel more comfortable telling my patients, at least my patients that ask about the risks of having surgery during a pandemic. I of course tell them I have to do the generalized disclaimer that it is still a pandemic and there's still a risk and it may be slightly increased, but I could tell them from my experience that all the appropriate precautions are taken to our knowledge, that they are likely going to be safe.
At our hospital, we are not allowed to mix COVID operating rooms with non-COVID operating rooms. So once it's deemed a COVID operating room, it's a COVID operating room and it stays that way. And so I find that very helpful. The thing that I learned the most about the pandemic and about not operating, because there was a period of time where I didn't operate. It was from about the 14th of March until about the early week in May, maybe the second week in May, something along those lines. When I first started operating again, I really got excited because once again, I was doing the thing that made me most happy. And I really became grateful that I had chosen the specialty that I had. And I really began to appreciate how much I love ENT and all the things that I'm able to do. And it's really a gift to be able to do the things that we do on an everyday basis, even though we're in the front lines and even though we're the ones that are up close and personal to this. But I'm so grateful for my mentors, and I'm grateful for my colleagues, and I'm grateful to have my patients to do the things that I love to do, and I love to operate. And the feeling of being in the operating room again, the excitement of the adrenaline rush and the sights and the sounds. I'm home again when I'm back in, and I hear the beeps and all the whistles, and I'm very appreciative, and I'm very glad that I chose the field that I chose. And it reverberates in my mind and my thoughts, and I'm so happy that we have this to go back to and to do every day. So
Great. Well, I can't think of any better concluding thoughts, Dr. Stachler. That was beautiful.
Gratitude for being here.
right.
Well, I just want to thank you both. Speaking of gratitude, thank you again so much for joining for this Zoomcast and, helping everybody stay up to date on what we've been trying to do to stay up to date and keep our practices evolving in the midst of a pandemic. So thank you both again so much.
Thank you.
Thank you.